High FM, 101.9 megahertz of life.
Joining us this morning is Dr. Daniel Israel. And over the last, we really started chatting about this last week, looking at various longevity and items as well as risk factors. Over the weekend, we heard about the really, really incredibly sad passing of Lisa Koppel, who it turned out, in fact, was suffering from cancer. And I wanted to chat to Daniel Israel about cancers. How preventable are they? How screenable are they? Dr. Daniel Israel, a very good morning to you. Thank you for joining us. Hope you are well.
Morning, Howard. Thanks for having me. So, cancers are definitely one of the leading causes of death today in the world, together with metabolic and cardiac and neurodegenerative diseases, which we'll discuss another time. But really important to focus on cancer because a good percentage of them are very, very preventable. There are those that aren't, but almost like if one listens to this kind of thing, it doesn't come into your mind straight away which ones are preventable, then you're doing yourself a disservice. And we all have the mindset of, this will never happen to me. Well, not we all, but a lot of the patients I see have that attitude. They'll come very quickly for a flu, but cancer, they say, I'm okay. I don't feel anything. I'm okay. And that's wrong.
Right. So what determines whether it's screenable, preventable? Is there a way to look at this?
Yeah. So screening as a whole should be looked at through a certain lens. And that lens is, you've got to look at, you only screen for conditions that make a difference in your life, just in broad terms. So the condition's got to be severe enough to screen for. The test has got to be a valid, suitable test that has a good sensitivity and specificity is what we call it. So sensitivity means that you're going to pick it up. If a test only picks up one in whatever, there's no point in doing the test.
Right.
And a sensitivity means it must only pick up that specific problem. A good example of something that has a good sensitivity, so it often picks it up, but it'll pick up everything as being a problem, is like, say, a PSA for prostate.
I was thinking about that, yeah.
Yeah, because people have enlarged prostates and suddenly the PSA goes up and the next thing they're having biopsies done and it's nowhere near cancer. So that's also important. And then 3 is that it's got to have a time where the cancer's not, there's no symptoms. So somebody who, for example, in pancreatic cancer, a patient will be fine, and then as soon as it's detectable, they're already very symptomatic. So that isn't something we go out and screen for routinely, but something that can go on for a long time before and can be stopped is screenable.
Right. So I would imagine that we should look at a whole bunch of factors, including genetics, including, obviously gender, age. How do it can be very overwhelming for a lay person to think about, I'm in my 50s, what should I be doing now?
Exactly. Okay, so I think that a more practical way of looking at this is to look at what's the top, say, 4 or 5 cancers are that can be prevented. And then maybe like next time we'll just mention those, but next time we can talk about per age, how you would remember what you're relevant for. But
so let's
starting
look at
on the
those.
story with Lisa Koppel, which is such a sad story. Colorectal cancer is probably the most preventable cancer in the world today. It's not the highest cause of death, lung cancer is, but colorectal cancer is, there have been guidelines that from age 45, a person should have a gastroscopy and a colonoscopy, even if they feel nothing, are totally asymptomatic, even if they're listening to this and say, yeah, but that's not me, you still need to do it from age 45. Now, the reason for that is on a colonoscopy and gastroscopy, the person doing the scope is able to see what's called a polyp, and some of the polyps are pre-cancerous lesions. Now, you can do as many X-rays and ultrasounds and CT scans and whatever you want, but you won't see that unless it's visualized directly under a camera. So if the colon is completely pristine, then often there's no need for a scope for 5 to 10 years after that. But if not, then it can be done even yearly. Now, the guidelines are 45 years old and older, but if there's a family history, particularly, it should be started much earlier. And in many centers of excellence in the world, they are starting to do routine colonoscopies and gastroscopies from age 40 or 41. I mean, Amazing. As we know, Lisa was 42. That speaks a lot to that one.
Right. What are the others?
Okay, so another one is breast. So from age 40, breast tissue becomes not too dense to do mammography. So before age 40, obviously, if someone feels a lump and it's something unusual for them, they should go and have an ultrasound done and check it out. But from age 40, every 2 years or so, a person should do a mammogram. And then obviously, again, in family history cases, like you were saying, different demographics, we would do it more often. But it's a simple thing that you can go to your GP and get a referral, or you don't even need a referral, I think, from a GP for a mammogram. You can just go to a breast center and you can have that mammogram done. Cervical cancer, the same. From a time of a person becoming sexually active, or say from early 20s, they should start doing a pap smear. And today our pap smears are so sophisticated that you can check for HPV viruses. And if those are positive, you'll screen and do more things. And if not, not. But even that's a bit of an awkward thing to go to a GP. Can be a GP. There are a lot of female GPs who do this today routinely, but it needs to be done. So that's that one. Then there's, lung cancer is interesting. Biggest cause of death in the world, but very much more in smokers than non-smokers. And thank God smoking is on its way down. But it can only really be screened for really well with a CT scan. So low dose CT scan. So we don't go and routinely tell everyone to go and do that every year. But if you're a high risk individual, smoker, family history, etc., you should definitely go and do that. And then just to touch on one more is prostate.
Yes.
So prostate's a whole discussion in itself. But basically, PSA is a valuable tool. We've been told so many times that it's not, and that you need a physical exam as well. But a PSA, if you're monitoring it on a yearly basis and you're looking at what's called PSA velocity, there's a big study done overseas that shows that if your PSA is climbing by like 0.1 and 0.2 up and down, it's not a problem. But if you see a progression in your PSA, even though it's in good ranges,
so in other words, you use it.
MRI.
Everybody should know what the baseline is and use that as the measure, not necessarily the number in of itself.
Absolutely. So hopefully through this, we'll unpack the fact that over the next couple of weeks, you'll be able to come out and say, I'm in this decade of my life. This is what I should be doing every year.
Absolutely fantastic. Looking forward to these discussions. Dr. Daniel Israel joining us this morning.